Opinions shared by the guests of the show are their own and do not necessarily represent the views of the host, Bindwaves, or the Brain Injury Network. This podcast is for informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of a healthcare provider with any questions you may have regarding a medical condition. Thank you.
Hi, I'm Carrie, a stroke survivor and a member of Bind. And today we're going to welcome Dr. Michael Canney. He is the Chief Scientific Officer at Carthera. I don't know if I said that right. He'll correct me in a minute. A medtech company driving innovative advances in brain cancer treatment. His work focuses on developing new therapies for glioblastoma, neuro-oncology, and neurodegenerative diseases. With over 50 peer-reviewed publications and a strong commitment to academic collaboration, Michael brings a valuable perspective on improving patient output. So I know I just said all that to introduce you, but how about in your own words, you kind of tell us a little about you better and maybe say all the words correctly?
Yeah, we can start again. Yeah. So the name of the company is Carthera, and we're a French medtech company with some U.S. presence. Obviously, I'm based here in Denver, Colorado, and we're developing an ultrasound system for delivering drugs to the brain. I think we'll talk a little bit more about today.
We will. Okay, sounds exciting. Okay, so just to get started, so what made you decide to get into the brain world, or even maybe more specifically, brain cancer research? That's kind of a unique field, in my opinion. I don't know, maybe not.
It is, yeah. I came about it a little bit through a different route, which is that I did my research as part of my doctorate in therapeutic ultrasound, which is using, ultrasound in new ways, not just for imaging, but for therapy. And that can be a lot of different things are being explored with ultrasound, from using it as a replacement for surgery, for actually destroying tissue, to drug delivery, which we're going to talk about today. And drug delivery is something that's been explored, at least for the brain, using ultrasound for about 20 years. And I got involved in a project while I was doing a postdoc in France with a French neurosurgeon named Alexandre Carpentier, who had the idea for the system, this ultrasound system that we've developed, which is an ultrasound implant that's placed to help with drug delivery for things like brain cancer.
Interesting. Okay, now that's when we say brain cancer. I know most people just think very generic brain cancer. So for myself and for the listeners, I know a lot, not a lot. I know a little bit about a lot of things, especially when it comes to the brain, being brain injured myself. But um so like how many different types of brain cancer are there? Because I know you're focusing mainly on glioblastoma. I never say it right, but um
Yeah, we're focused on, these types of primary brain tumors. You can divide up brain tumors into primary and then secondary brain tumors, which would be a brain tumor, say like you have breast cancer and you have metastases that goes to the brain. That would be a, secondary brain tumor. But we're really focused on these primary brain tumors called glioblastoma. And here in the U.S., they affect, around 10,000 people a year. And it's a very aggressive tumor. It's the most aggressive brain tumor in that, there's very few treatment options. And once a patient gets a glioblastoma, their survival is fairly short. It's on the order of 1 or 2 years.
okay, yeah. So okay, so I know we partner with a group here in North Texas area called Gray Matters. They are a brain cancer support group. So we
Hmm.
kind of collaborate with them to do stuff. We're all different kinds of brain injured survivors here, but we do have some with tumors and some cancer, and then the typical stroke and traumatic brain injury, all kinds of random things. So, are there specific factors that make brain cancer so deadly? Or, why is it? I guess, you know, do we know why it's what it is? Or,
Yeah, there's a lot of reasons that we think, but we can just start with the basics. So if you get a glioblastoma, the first thing they'll typically do is surgery. So a neurosurgeon will go in and they'll try to cut out the tumor just like they would with a different kind of cancer. The problem with glioblastomas is typically is that they're infiltrative, and so when the surgeon goes in, they can cut out most of the tumor that they see, at least on the MRI, but we know that they can never really get the whole tumor, and so typically in 6, 12 months, sometimes longer in some patients, the tumor will reoccur because there's still some tumor cells that are infiltrated in the brain that the surgeon isn't able to resect. And because of that, and these cells that are in kind of infiltrated in the normal brain, they're protected by something called the blood-brain barrier. And so the blood-brain barrier really restricts what can get into the brain. And so if you take something like a drug, a therapeutic, and you give it to someone who has one of these brain tumors, very little of the drug may actually get to the tumor because of the blood-brain barrier, which is really just protecting the brain, from potentially toxic substances and things that could actually injure the brain. But here, when you have a brain tumor, these tumor cells can actually kind of be hidden behind the blood-brain barrier. And so when you give a therapeutic, it may not actually get to those tumor cells.
Okay, so yeah, I know a little bit about the brain blood barrier because, like I said, someone from Gray Matters came on, and his wife had that issue. The treatments that she got, I mean, was a long time ago, but yeah, and she's actually still alive. She's doing well. But it's interesting. Some of the treatments that she got were like new at the time, and they were like, just do it and let's use it as research. And so I don't remember what it is. You could go back to one of our podcasts and listen to it. But um, so let's talk, I guess, then a little bit about this new treatment technique. Because, like, I mean, first of all, let's go back to ultrasound because that's very interesting to me. Because, yeah, when you think ultrasound, you think, first off, you think babies. I'm going to ultrasound a baby. I'm still trying to get the concept of how an ultrasound delivers medicine, I guess, because, that's unique.
Yeah, so I mean, ultrasound can do a lot of things, and so we use it for imaging. That's a modality, obviously, that's been studied for decades and decades and decades. But the therapeutic uses have also been studied for a long time. You can imagine, I mean, if you just turn up the power on your ultrasound system, you can actually heat the tissue because you actually get enough energy in there. You want to avoid that when you're doing imaging, but if you're doing a therapy, you may actually want to heat the tissue and kill it. So that's a therapeutic mechanism that you can use with ultrasound. Here with drug delivery, what we do is we actually couple the ultrasound with a microbubble. And so when we do our therapy, and our therapy is an ultrasound implant that gets placed, replacing the skull bone when a patient gets a tumor resection. We were talking about surgeon goes in and cuts out the tumor and places this ultrasound implant. When they get the system activated, though, when they get a normal chemo or their drug therapy that might follow the surgery, the patient gets the device activated at the same time as they get a microbubble agent that gets administered. So you can think of like a bubble that's actually going through your blood vessels, and these bubbles can actually respond to the ultrasound and vibrate in response to the ultrasound. And actually, this mechanical kind of interaction between this bubble and the vessel wall is what can actually disrupt the blood-brain barrier. And so we use this kind of synergy between the ultrasound and these microbubbles that we're giving to disrupt the blood-brain barrier.
Okay, that's that's okay. And so, how new is this treatment? I mean, are y'all still
Yeah,
in the study phase or?
yeah. So it's interesting question because they've been looking at this kind of technology for over 20 years, about 25 years. First paper came out in 2001 by this researcher named Claire Vohinanen that was really a pioneer in the field. And since then, there's been a lot of engineering developments to bring it to human patients. And one of the big issues in bringing this kind of therapy to the brain is actually the skull bone. So when you have the skull and you try to give ultrasound, that will actually absorb most of the ultrasound energy. And so you have some issues in applying ultrasound in a safe way to the brain when you try to use it for something like this. So there's a lot of companies working on overcoming that and sending ultrasound through the skull safely. Our company is a little bit different in that it was founded by a neurosurgeon who said, I'm going to have this neurosurgical procedure, and at the end of the procedure, I'm just going to place an ultrasound device in the bone window that I've already opened for the surgery. And so we place the ultrasound device at the end of this surgery, and then we can use it during each drug session when basically a patient comes in for a chemotherapy. They can get the blood-brain barrier disrupted at the same time as they get a normal drug therapy.
Okay, interesting. And so, speaking about that, makes me wonder. I mean, is this a viable option for everyone that has this type of brain tumor, or is
Yeah,
there
yeah.
some that maybe don't qualify?
So going back, yeah, sorry, I didn't respond to your full question, but going back to the human clinical trials, as they started, some of this research in the early 2000s. We and some others treated the first patients around 2014 that were this. So this was the first in human trials with our system. And since then, we've run a bunch of phase 1, 2 trials, and we've recently initiated a phase 3 trial. So this is still an investigational device for treating glioblastoma, and we're in a phase 3 clinical trial in the US and Europe that we hope to finish recruitment in by the end of next year. And so the patients that we're treating, you're asking about specific patient populations right now. In our phase 3 trial, we're treating patients that have had recurrence of their tumor. So they've already had this initial surgery and initial chemotherapy, and they've had a recurrence, so the tumor has regrown, and then they can come on our trial. But we're actually looking at using our system in all kinds of patients, in patients who are just diagnosed with the disease, and in patients who recur, and looking at different therapies that can be coupled in those different stages of the disease.
Okay, so you are still in the trial testing phases of everything. Okay, and I mean, sounds silly, but I guess your preliminary results are looking fairly well, fairly good. I don't know the proper way to
Yes.
say that.
So we published 2 papers in the last couple of years from some phase 2 trials that we did with different drug therapies. And so the drug that we're advancing with right now in our phase 3 is a drug called carboplatin, which is an older chemotherapy drug that doesn't really cross the blood-brain barrier well, but that has shown some efficacy in glioblastoma. And so we really think if we can improve the penetration of this drug, we can really increase the efficacy of the drug. And so we published this article in Nature Communications last year that showed our phase 2 results, showing an improved survival in a small cohort of patients who had received this therapy, and that's what led us to initiate this phase 3 trial.
Okay, and I mean, I'm imagining because I mean, the brain's not that big. Everything up there is not that big. So I'm assuming this implant that you put in is teeny tiny. I mean, I mean, I don't know. I'm just like, we occasionally watch, but we just watched a documentary and I don't remember the neurosurgeon's name, but there's a new neurosurgeon documentary on Netflix that we just watched, a brain tumor removal. It's interesting. I'm trying not to make my faces that I made when I watched the video, but I think about implants and I always, wonder like how big is that? And what are the risks, I guess, involved with implanting something into the brain? I mean, I know there's other things that get implanted into the brain. I know it's not crazy to think about. It is to me, but
Yeah, I mean, I actually think it's going to be more and more common. I think we see this, companies like Neuralink and different brain-computer interface companies. In my opinion, I think brain implants probably become a lot more common as we advance, across different indications, maybe even things like stroke, which you mentioned. But yeah, in terms of our implant, we have this device which is about 6 by 6 centimeters, and so it's really sized to fit, a normal size bone flap that a surgeon would open up anyways, to access the brain for
okay,
surgery.
interesting. So, can you feel it on your head when you touch it, or it goes under the bone?
Yeah. Yeah, so you talked about the side effects. I mean, any brain tumor surgery has some risk of infection. We haven't necessarily seen a higher risk of infection from placing our device versus just putting back the other bone flap. But obviously, this is something that we're indeed looking at in our phase 3 trial, whether there are any other risks. But so far, we've seen very minimal side effects from placing this device. A lot of patients have kept it for years, not had any issues with it. and it really is not directly in contact with the brain. So you still have this protective layer, the dura mater, which is covering the brain actually, and this device rests, outside the dura mater. So it's not directly in contact with the brain. It's really just replacing the skull bone that was there and then sitting on the dura mater. And the device that we've made is made of this mesh. And so this mesh is something that a neurosurgeon would typically use if they had to fill in, a bone defect in a patient. So they're very used to actually placing this kind of device. And just under the mesh, we have these ultrasound transducers that are connected to it.
Okay, great. I'm going to take a quick little break and just remind our listeners that while you're listening, go ahead and click that like button, click that share button, click that notify button so that you can get all the other episodes that we have going on. And then now let's see if I can remember what I was going to ask after that. I know. So that device where it's sitting is not, it's on the outside of the blood-brain barrier, but near the blood-brain barrier. Would that be correct? Am I getting?
Yeah. So you're getting at something. So ultrasound has a pretty good penetration. And so the frequency that we're using is a 1 megahertz. And so at this frequency, we get disruption of the blood-brain barrier up to about 6 or 7 centimeters. So ultrasound can penetrate pretty deeply, way. You don't necessarily need the ultrasound, like you said, just sitting right on the blood vessel
Right.
to disrupt it. Yeah, it's one of the advantages of ultrasound versus, some other modalities of energy is that you can actually have it at quite a distance and still have a therapeutic effect in this case.
Okay. And I'm not going to just guess at what you're hoping to achieve through this work. I want you to let me know, like what's the ultimate goal? What's the maybe short term versus long term? What are you looking to achieve?
Yeah, so this trial is a phase 3 clinical trial that we're running right now. The goal of a phase 3 trial is really we're randomizing patients, and so patients get randomized against the standard of care that they would normally get if they weren't in a clinical trial, and then half the patients get randomized into getting our device in combination with this carboplatin chemotherapy, which is what we're using. And the ultimate goal of this phase 3 trial is to show that we can extend survival for patients that are getting our device. And so, this initial trial, if we can significantly improve survival outcomes for these patients with recurrent glioblastoma, I think that's a first step. And that would show this technology of disrupting the blood-brain barrier, increasing drug concentrations, really has an effect on the tumor growth and slows down the tumor growth and maybe stops it in patients to extend survival. I think after that, that's really a first step, and we're looking at a lot of different therapies that could be coupled with the device. And so carboplatin that we're using right now is really just a first step. We're also looking at things like immunotherapies. We're looking at other drugs that could be used. And so eventually, what I could imagine is a patient may get diagnosed with the disease. They may get the implant right up front when they get diagnosed with the disease, and then we may eventually be able to follow them as they get different rounds of different therapeutics, so that all these drugs could actually be increased in the brain by disrupting the blood-brain barrier.
Okay. Cool. I'm trying to think if I have any more questions about that. The brain is so amazing to me, what it can and what it does, and how it can rejuvenate itself, and all the crazy things. So, what would you say is one of the most rewarding things about your job?
I think being able to do something that has an impact. This is, a disease that really has a high unmet need. There's been a lot of failed clinical trials over the past several decades. We're not just developing something that's kind of like a small improvement, I think, on some medical technology that exists already. This is actually kind of a brand new field that still, I think, has a huge potential, not just in glioblastoma, but other diseases as well that we're looking at. So, this group's looking at Alzheimer's, I think Parkinson's, ALS, and so, the therapeutic potential is much even beyond this indication.
Okay. Yeah, that was going to be one of my other questions. Do you see this being used in other areas? And so, yeah, it sounds like. hopefully that will lead to more trials and other needs and go from there. So,
Yeah, yeah. In fact, yeah, I mean, everyone working in the brain area, treating no matter what brain disease is struggling with this because you can try to engineer drugs that cross the blood-brain barrier. You can try to use small, basically very small size drugs, sometimes cross, but if you just limit yourself to these things, you really, have a very small toolbox of things that you can use against these brain diseases. And so once you can expand that, you open up a lot more possibilities in terms of what's possible.
okay. And now I'm going to ask a more generic question that's kind of a question that I, again, I'm relating back to us as brain injuries now. And I know I've asked this question and I know the answer, but just in case we got new listeners. So, just because you have brain cancer and you have a tumor removed or partially removed and you're going through this treatment, that does not necessarily mean you have a brain injury, correct? I mean, it could lead to a brain injury, but not everybody that has a brain tumor and has a brain tumor removal ends up in the brain injury camp. Does that make sense what I'm trying to say?
No, you're exactly right. I mean, so usually, a surgeon, when they go in and they do surgery, their goal is to resect as much as possible without causing any harm to the patient. So you don't want to affect the patient's
Right.
quality of life. And so, I was just at a surgery last week, for example. It was an awake craniotomy. So they'll actually do brain surgery when a patient is awake, and they'll test functional regions while the surgeon is, measuring to see, really make sure that they're not going to have any functional impairments in the patients. And that's pretty common for these kinds of surgeries that a surgeon would do that. Um, that being said, there are cases where a patient does wake up and the surgeon potentially has touched something that they shouldn't have, or there are sometimes side effects that happen. But
Right.
um, for the good surgeons who are being careful, I think I don't know what the percentage is exactly for it to, these kinds of patients, but generally, I mean, we see the patients after surgery and they're doing well.
Yeah, that's interesting because the documentary I was telling you about, that the guy was awake for that, and that was just crazy. He's like, "Okay, tell me if these musics are different." And so, like, yeah, they were asking him questions all throughout and having him do different things. So, but yeah, and then just again, and what is one thing that maybe you would like our listeners to know about, I don't know, brain cancer in general, or is it glioblastoma or geoblastoma? I think I'm saying it wrong.
Glio.
Glioblastoma. Okay. Um, what is like one major thing that you would like listeners to know? Like maybe they don't know. Like what could they find out about? They don't know they have it, but then it shows up, because I assume that's kind of what happens, right? You don't always know you have brain cancer.
Yeah, I mean these kinds of tumors show up. I mean the age demographic tends to be from 30 to 70, 80. I mean they show up across all ages. And so I think most people seem to know someone, even though it's a pretty rare tumor. Most people have somehow encountered this, some know someone or a friend of a friend or something that has had a glioblastoma every time we mention it. Um, but getting back, let's see, your question was
Like what
something's,
something that you want to make sure that people, just the general public that maybe don't really understand, something that you want them to know about it, like how to find it or be prepared or react, or what I mean, like we know there's
yeah,
stroke signs to look out for. We know there's signs for heart attacks. Is there something that
yeah.
maybe
Unfortunately, I think for a tumor like this, there's very little. Most patients may have a seizure or headaches or something. They typically have a neurological symptom that's basically caused by the tumor growing, that triggers them going to the hospital and getting an MRI, to where they actually learn that they have this tumor. They typically also need to do a biopsy, they can be pretty sure, but until they go in and actually take out the tissue, they're not always certain that a patient actually has this kind of glioblastoma, because there are primary brain tumors that are less aggressive, that can form and look similar. So that's also possible.
Okay, well, Michael, thank you so much for joining us today. This is also interesting, and maybe let's circle back around next year after you're done with the trials, and let's see where you are and get an update from you. That would be pretty exciting. So, but we want to
Yeah, that was,
thank you again for being here.
yeah, thank you so much for having me on. And, if any patients want to learn more about this trial, we do have a website. It's sonobird.eu is the website for the trial. And the name of the company is Carthera. So carthera.eu is the company if they want to learn more.
And we'll make sure that we spell it correctly in our description. And links don't really work in Instagram, but if you have an Instagram, if you'll email that to me, then we'll make sure we tag you in our Instagram story so that people can find you that way. But yeah, we'll get that figured out. We'll make sure we get people to you. And then again, I want to thank all of our listeners for listening. Again, if you want to contact us, I know you get tired of hearing it, but our email is bindwaves@thebind.org. I almost said .com. And you can follow us on Instagram at symbol bindwaves, and our website, thebind.org/bindwaves. So don't forget again to click the like button, the share button, the notify if you want to watch us on YouTube. But you can find us on all your favorite platforms. So wherever you listen to podcasts is where you'll find us. And just keep listening, and we'll see you next time. Until then, have a great day. We hope you've enjoyed listening to Bind Waves and continue to support Bind and our nonprofit mission.
We support brain injury survivors as they reconnect into the life, the community, and their workplace.
And we couldn't do that without great listeners like you. We appreciate each and every one of you. Continue watching. Until next time.
Until next time.